Very good morning. Okay. So I have no interest, rather no financial interest, and I disclose that. But I have too much interested in spreading the ECMO awareness. And after two and almost 2 days complete, and this topic is a different topic. This is known as half ECMO. Whenever the patients require not to support the oxygenation but to for the only the increased CO2, the hypercapnia, we use this kind of thing. So my topics will be divided in definition, origin of the concept, clinical evidence, types, complications, like other speakers. And I found I have written a lot of unnecessary slides. I will go through this. The first slide is what is ECOR. ECOR is a technique with partial respiratory support that achieves control of carbon dioxide from the blood through a low blood flow, up from 400 to 1 liter per minute, without significant effect on the blood oxygenation. So the beauty of the carbon dioxide is it's a very diffusible gas, and it can be easily taken out by using lower flows. So that is the concept of deviating from the proper ECMO when you want to take out the carbon dioxide only to a lower flow system through an ECOR device. So with that thing, the history started long back in 1978 with Theodore Kolobo, with this breathing control of breathing using extracorporeal membrane lung, and they have found that alveolar ventilation was proportional. Decrease in the alveolar ventilation is proportional to the fraction of the total carbon dioxide removed by the membrane lung. And when extracorporeal CO2 removal approximated the carbon dioxide production, alveolar ventilation almost ceased. So with that thing, they have used in this technique on those days in patients with uncontrolled bronchopleural fistulas, where the ventilation was almost impossible. You can't ventilate whatever you're giving going through that leak, and the CO2 is mounting up. So they devised something to take out the carbon dioxide through an extracorporeal site, so that without using the lung, and if they can avoid the positive pressure. Now, after that, lot of publications came from Dr. Gattinoni and Theodore Kolobo with low frequency positive pressure ventilation with extracorporeal, and then they shifted this idea where they are finding these acute ARDS situations with the decreasing in the tidal volume with the permissive hypercapnia, and hypercapnia will be managed by this extracorporeal circuit. So practically speaking, if you see that this extracorporeal CO2 removal has actual two roles. Number one is the pure type 2 respiratory failures, where patients are basically coming with a mainly hypercapnia, like advanced COPD, like a 75-year-old COPD who had got admitted in your hospital many a times before, and relatives or he himself doesn't want to go for ventilation, but his CO2 level is more than 100 and he came to you as drowsy. What you are going to he's maintaining oxygenation, but he cannot take out the CO2 level because of the acute exacerbations. So what to do with that patients? And second one, the patients of acute ARDS whom very high pressures of the lung, you don't want to give too much of tidal volume to decrease the barotrauma, volutrauma, and lot of atelectative trauma, whatever the things are there. And there is a mounting of carbon dioxide that is known as a permissive hypercapnia, and you want to reduce that. So it's a conjoined technique of using low tidal volume and with the to keep the carbon dioxide at the level of the permissive hypercapnia level with CO2 removal. So these are the two indications where this ECORD is going to be helpful. Lot of publications came with different results. Few of the publications shows the expected mortality is more than 90%, lung function improved in 72.8%. So these are the publications we'll found everywhere in the net. And this is one the article from the Morris and Wallace CJ, and they have done there's no significant difference in survival between the mechanical ventilation and the extracorporeal CO2 removal groups. We do not, so they have not recommended any CO2 removal is going to be a helpful technique in giving good outcome. But after that, we adopted this technique slowly with a good understanding that it can be used as an adjunctive therapy in ARDS. And this article came in 2000 where people are using started using this low tidal volume thing in ARDS. To cut this carbon dioxide level, we have started using extracorporeal CO2 removal as an adjunct to the ARDS. So if you see the tidal volume reduction in patients with acute lung injury when plateau pressure is also high. So these papers came out, and the problems of mechanical ventilation also went down with the using of lower tidal volumes along with the CO2 removal techniques in ARDS. So soon the lung protective ventilation thing came with the tidal volume of less than 6 ml per kg and plateau pressure of less than 30 with the permissive hypercapnia. And again, you are using ultra protective lung ventilation with tidal volume of less than 4 ml per kg with a plateau pressure of less than 25. The CO2 was mounting up, and just to control that, you can do that thing known as ECOR. So we know all that what are the effects of hypercapnia in the lung and the hemodynamics. It enhances the pulmonary vasoconstriction, increase mean arterial pressure, increase RV afterload, and lead to an RV failure. So we have to take control of the carbon dioxide to a level, at least it should be kept between 50 to 60 during the ARDS things. And obviously low tidal, this is the paper which came out with the using of this pumpless extracorporeal lung assist device with further lower tidal volume strategy of less than 3 ml per kg. Now, this was the study done by Dr. Alan Coombs and Marco Ranieri, the supernova study, properly randomized study with the feasibility of Safetyol ECOR to enhance protective ventilation in acute ARDS. It facilitates the ultra protective ventilation tidal volume of 4 ml per kg with a plateau of less than 25 in patients with moderate ARDS. Look, this study has been done in moderate ARDS and along with the ultra protective lung strategy with ECOR. And they found there are 95 patients enrolled, and ECOR was maintained for 5 days. They found the 6 severe adverse events reported, 2 of them attributed to ECOR and brain hemorrhage and pneumothorax. ECOR was reported 39% of the patients, ECOR adverse events, and 59 patients were alive till discharge. So that was a good study which came out with the establishment of the ECOR techniques. Now that came the ECLAIR study. A lot of studies for this adjunctive role in the ARDS came out. And then also the ECOR came out as a COPD, which you are telling the purely hypercapnic patients where they are using ECOR technique. ECOR, how it helps in COPDs, it decreases alveolar ventilation demand, lower respiratory rate, increase expiratory time. So it actually increases the carbon dioxide elimination and decreases the carbon dioxide production. It helps physiologically also in COPD patients. And if you go to the physiology again, 200 ml CO2 we produce per minute. CO2 is mainly carried out of the plasma. That's why I told you it's very easily diffusible. It can be taken out, like a CO2 removal rate can be easily maintained at the less than 1 liter of per minute blood flow. So normal ECMO flows, larger ECMO flows are not required, and CO2 diffuses more readily than oxygen in the extracorporeal membrane. So coming to the methods, these are the scientific basis of using ECOR. Now, how we do this has to be known. ECOR, it can be divided in this arteriovenous ECOR, early forms of venovenous ECOR, and the modern systems of the venovenous ECOR. Out of that, different ECOR systems are there. One was the pumpless system, that is the arteriovenous. Here, no oxygenator or mechanical pump is the mechanical pump is used. We put an arterial cannula, we put a venous cannula. Because of the arterial pressure, it creates the carbon dioxide gradient, and the carbon dioxide comes out. The problem is again with the arterial cannulation and the cardiac failure, hemodynamic instability. You cannot use that. Pumpless systems of, that is the arteriovenous. We no more use this. And this is the configuration, one placed in arterial cannula, one placed in the venous cannula, and the arterial pressure actually drives the blood through the oxygenator and takes out the carbon dioxide through that. And this is the way we do this. This is known as PECLA. VV-ECOR is the today's technique what we use regularly. There are few industry circuits are there. There is the ILA active centrifugal pump with a diagonal flow. DCAP system, I will come to that later on. Pump assisted lung protections, PALP, and the Hemolung system. Costly, but they are effective. ILA active, again, they do different flow rates. It has a 0.5 to 4.5 liter per minute. It can be used as an ECMO also. DCAP, the system what we are using regularly in the hospitals. The patients, the blood taken out, it goes through a lung membrane. Again, it goes through a filter, and through that the carbon dioxide taken out. The plasmatic water is again gone back to the circuit before the membrane oxygenator, make it diluted, more efficient CO2 removal, and the less requirement of the heparin. Actually, the membrane lung and the this filter is connected in the series that I will show you. And this is an Hemolung system. These are the industry-driven systems are there. Now, you can use ECOR as a part of the CRRT. You can take out the blood from the CRRT where you are actually it goes through a membrane lung, then it goes through a hemofilter, and then the CRRT goes on. So you can connect a membrane lung, a oxygenator in your CRRT circuit to take out the CO2, and where you are put the sweep gas in the system, and sweep gas is out of that way. That is the way you can. And there are a lot of adverse events reported, obviously, which are mainly related to the cannulations and the bleeding anticoagulation system that will be taken care in the other lectures. Uses, I told, the bridge to recovery in severe hypercapnia, mainly COPD, advanced COPD patients, ARDS as an adjunct therapy of the low tidal volume ventilation, acute exacerbation COPD or asthma, thoracic surgery during that typical bronchopleural fistula, and sometimes a bridge to transplant patients where CO2 was mounting up on the waiting for the transplant, lung transplant patients. And limitations, it doesn't give any help for the oxygenation. If you want, there is a worsening of hypoxia, you have to go back to the ECMO. And definitely no guidelines, and obviously it cannot be used because of the low catheter size in pediatric patients. This is the ECOR diagram. We are taking the patient, the blood out from the patient, going through a pump and pushing that blood to an oxygenator where the oxygen is connected with the sweep gas, and you are going back after the carbon dioxide taking out, it is going back to the patient. Now, two cases are there. There's a 28-year-old male admitted with fever in 3 days, respiratory distress, typical ARDS patient. This was the picture, and this was the before intubation. The PO2 was PCO2 was 28, PO2 39. After intubation, proning, PCO2 89, PO2 73. Then improving all this, with the FiO2 70, we managed a PO2 of 171, but the PCO2 is 78, but the pH is 7.23. Then we took that patient on ECOR. So this is the circuit. If you can see, if you have any question, you can ask me after this. There is the oxygenator, the pediatric oxygenator, which allows a flow up to 1 liter, and hemofilter which is connected in the series, and the sweep gas flow is connected over there. You can see the blood is coming out, coming in the oxygenator, and blood is coming out of the oxygenator and is entering to the filter, and you have this sweep gas flow which is connected over here. Why the filter is downstream kept for the beyond the oxygenator? Because I told you in the decap, this is a modified decap system where the filter resistance is actually producing more efficient CO2 removal on the membrane lung. So this is the way we do. You just look at the thing. This is a very reproducible technique you can practice in your place without an ECMO machine, and this is through a your normal dialysis machine or the CRRT machine. This is the second case. 85-year-old male with a fever, cough, running nose came to us and got intubated, had ET tube dislodgement, and then reintubated. And this was his lung. It's a severe uncontrolled asthma. ABG was like that. PCO2 was 93 and PO2 was 99 with the FiO2 of 40%. So oxygenation was not a problem, but we could not come down on the PCO2 level. We tried for 2 days with change of ventilatory settings, but we could not do. And ETCO2 remained around 70 with the PCO2 of more than 100. And then this was the ventilator area, the peak pressure was mounting more than 40. And we have been distressed, so we have been called, and we started ACORD on day 5 with the same technique. And we put a dialysis catheter, and the flow around we give 500 to 600. And this is the technique. This is the dialysis machine used for an ACORD. It slowly came down on the oxygenator, and we also taken the patient on sevoflurane because there's a silent chest and the bronchospasm was going on. It also to take care of the this bronchospasm thing, and it was continued. On day 3, there was a clogging of the oxygenator, so we had to change the oxygenator. There is a sudden rise in PCO2 which was coming down with that, and slowly everything started improving. As the PCO2 goes down, the requirement of vasopressors went down, his requirement of sedation came down, and finally on day 13 we could take out of him from the ACORD with a normal carbon dioxide level. And this was the X-ray. You can see the dynamic hyperinflation has been resolved, and he was put on CPAP, and this was the ABG with a 40 PCO2 of 138 PO2 on CPAP, and we could extubate with these are the hemodynamics with 39 ETCO2 with that hemodynamics, and we could extubate him. So this is a very reproducible technique. Even if you don't have that ECMO machine in your center, you can do it with your dialysis machine, provided there is an isolated hypercapnia or it is an adjunct to the management of ARDS, where you are using the lower tidal volumes to protect the lung and to make a hypercapnia within the permissive level. You can use it as an adjunct. So any doubts, I am ready to answer. Ma'am.